Vice Chairman of the University of Erlangen, Nuremberg, Department of Otolaryngology, Head and Neck Surgery, and he's going to talk to us about managing parotid strictures. Thank you very much, Professor Zenk.
Yeah, first of all, thank you very much for this nice introduction, and thank you very much for the invitation to come here to Ireland, to Dublin. It's my first time to stay here, and the weather is beautiful, like always, I've been told. And no, really, I mean, I really enjoyed last evening, and I've heard that the weather will be stable also the next week, so for the people staying here, it's very nice. And this is the clinic I'm working in. The first head of our department was Professor Kieselbach. Maybe somebody of you knows the locus Kieselbach here at the septum. Next year we will have the 125 years of ENT in Erlangen. So yeah, quite an old clinic really. But let's go into the topic. How can we have heard something about diagnostic means, also in stenosis and strictures of parotid glands. So what is very important, of course, is the patient's history and the clinical examination. We don't have to miss this. Yeah? And then we go for imaging. Normally, we in Germany, we are very used to ultrasound because every ENT and maxillofacial resident has to learn ultrasound on its own hand. Not the radiologists do that in these subjects. And then, of course, you could do conventional xylography. We never do that, really, only if there is any interesting point. But I know, especially if you talk about strictures, Mark McGurk told me it's better to see the length of the stricture. But we get along with the ultrasound. We don't have really problem with that because then we also could do also MRI xylography, quite a new method, and we have heard about CT and DVT xylography. Let me only say some word to DVT xylography. Everybody always tells us there is less radiation, and this is, I think, not always true. You cannot mix up apples and other fruits. I think it's nearly the same radiation you get with both methods because you can go down in CT with a radiation dose. You have to keep that in mind. Well, when you talk about strictures, there is really a very nice paper from Mark McGurk's group, and they made a lot of effort with their 1,362 xylograms. And within that paper, it's very nice that you can think about how often strictures, duct strictures, will be seen in parotid glands. And you see that in 15% of all these xylograms, they have seen duct strictures, and 2/3 of them are single strictures, and 75% in the parotid gland, and more common in women than in men. And the mean age is 52 years of age. So altogether, we can say normally we see these strictures in women around 35 to 55. And this is also our experience we have. Why don't we perform xylography? Because we have ultrasound. We don't use it because of maybe allergy and contrast agent, and it's not very useful in acute sialadenitis, and quite often these patients have problems. And there's also radiation, of course, but this is not very big. So we use ultrasound, a B-scan sonography with 7.5 to 13.5 megahertz. Color-coded sonography included. You have seen that also in Carpaccio's topic. This is what we can see normally when there is a pathology. You see the dilated duct here, yeah? It's not. Yes, the arrow, you cannot see the arrow here. Okay, it's not seen in that, so I have to show you. So, yeah, we have to shut the light down. Yeah, you see, even if you don't see a stone, you see the dilated duct. And whenever you see a dilated duct in sonography, there is something that is, can you see it very well now? Here, yeah, the dilated duct, and maybe here is a stone or maybe a stricture. So whenever you see a dilated duct, there is something wrong with the duct. And also here you see the dark gland, so there is a congested gland, and that is for us the indication to perform the next step in diagnosis. But first of all, there's a small trick you can do, and you can tell your radiologist, just take some vitamin C powder, a spoonful of vitamin C powder. The patient can take it, and then the gland will immediately start to produce saliva, and if there is a pathology within the duct, you will see that immediately. This is before and this is after vitamin C, and you see, because of the production of vitamin C, you see the dilated duct much more better. So I think with this method, you nearly can see any pathology you need to see. And even with this method, very small stones, very distal, or even as an indirect sign. And then you go on with the next thing. But what we have, what is quite new, we have now a new ultrasound machine for intraoperative use, and also together with silendoscopy and together with all our methods for stone and for the treatment of stenosis. This is without any cable at the moment, so it's very easy for us to really go directly for the intraoperative use. And if somebody is interested in ultrasound, well, we published just a few months ago a new book about, it is Atlas of Head and Neck Ultrasound, and you can read everything in that. Also, not only salivary stones, but also the vessels and the head and neck, the lymph nodes, and also the thyroid tissue. So this is maybe a good investment also for head and neck surgeons, not only for radiologists. So the next step, when we have done this, so we see something, a congestion of the duct, a dilation of the duct in ultrasound, we will go on for silendoscopy. Yeah, and it's very nice because in stenosis of the duct system, this method we think is superior to all other diagnostic means because we can directly see the pathology. And we can characterize the stenosis, the localization, the number, the length, the grade of stenosis, and the tissue quality. These are the endoscopes we use from Storz company, 3 different endoscopes with outer diameters of 0.8, 1.1, and 1.6 millimeters. These millimeters are due to the diameters we had found before, with 1 or 2 channels and irrigation and working channels. This is the diagnostic one, 0.8. You see one working, one irrigation channel and the optic channel. And this is 1.1 endoscope. And we also have these centimeter scales. This is 5 centimeter here, that we exactly know how long the stenosis is, how far it is inside, and even with stones, this is very useful. So what we did in the past, we tried to get a system of the stenosis. So we just made different types of, we defined different types of stenosis, which we could see and characterize clinically. So type 1 stenosis for us is the inflammatory type, you can see here. So you really don't see a stenosis, but you see that there is something happening within the duct. There is not a normal duct wall. There is some fibrin or whatever kind of protein material inside. That is not quite true, not very well known. And maybe there is some small signs of webbing and beginning of strictures at this part. But patients have already complaints with that. And the second time, in about 18.5%, are these fibrotic and web-associated stenosis here. So you see a dilated duct, and within that dilated duct you see these webs with these segments of stenosis. That is our second type, and the type 3 is the most common one, and we see that in about 2/3 of all parotid stenosis, and this is really the fibrotic and very difficult to open one. This is a type 3 one. We just try to open it here with a basket and a drill. And sometimes these stenosis are very long and very difficult to treat. So according to this classification, I will show you in the end our results. I know there's another classification from Marshall, but this is a very theoretical one. But this one I think is a quite nice clinical one. Of course, we use instruments for treating stenosis, like baskets. Why do we use baskets? Because if they are not so elastic, if they are more stable, you really can push it open. And we can use also these forceps to open stenosis and small drills and also balloons and the other drill you see here. That is what you can use. Interestingly, I want to go back a little bit on the pathophysiology. How far should we go? And there was quite an interesting publication, I think it was last year in the laryngoscope, and this is from a Chinese group. And what they did is they just made a CT scilography-based model, and they compared it to the patient's symptoms. So it is a calculation of pressure independence of the duct diameters 23 millimeters away from the ostium. And interestingly, these were the calculated pressures without stimulation and during stimulation. And this is really interesting. What they saw is that the pressure goes up when there is about 80% stenosis, and also the blockage ratio more than 80% also during stimulation. So, and they made a drawback to the symptoms of the patient. So I think the symptoms will appear when the stenosis is more than 80% normally. That's really a very interesting, theoretical, but interesting paper. So in the end, we have to ask, how far do we need to go? We know that the diameters of the salivary glands are about 1.5 millimeters in mean. So we think, and this is our experience from more than 2,000 endoscopies during the years, that a duct is open or is patent when a 1.1 millimeter endoscope passes through. This is our opinion. I don't know whether the others have different opinion about that, but it is then more than 50% open, and it should not give the rise for any symptoms really, despite some other obstruction is happening. Often already with a 0.8 millimeter endoscope. So based on these findings and on these theoretical things, our treatment strategy is first just to perform silendoscopy, to pass through the stenosis with irrigation, and maybe in case of inflammation, we perform intraductal cortisone application. Prednisolone, we mix 250 milligram in 100 milliliter of the solution, and then we just use it for irrigation. That is what you can do, but nobody knows exactly why this should work. This should be some kind of investigation we have to do in future. Second part would be, if that does not work, the interventional silendoscopy, together with endoscopic controlled dilation, plus minus ultrasound or stent. And if that does not work, we have to use a combined approach, silendoscopy with transoral duct surgery, maybe vein patch or transcutaneous approach. Very seldom we do that. This is for the very difficult cases. And I do not know really whether a vein patch will always work. We have made our own experience, at least with one patient, it didn't work at all, and I don't know, maybe it's better than to remove the gland. So, especially if it's for a long distance and not only for part of the duct stenosis. And in the end, if that's not possible, you can remove the gland, or before you do that, you can ligate the duct, you can do that, and of course you can use Botox just to get relief of the symptoms. I would like to show you some examples. This is a 56-year-old patient with a recurrent swelling of his left parent gland for years. Normally we think when the duct is closed, the symptoms should disappear, but in many patients they don't disappear. So on the other hand, my thinking is sometimes, why should duct ligation work if it doesn't work in these patients? I don't know, and maybe somebody can give me some answers. So you see here, this is the dilated duct, and maybe there's still some opening, and here is the stenosis. And exactly this patient we saw then later in endoscopy, and it was closed completely by a membrane here. So what we did, we performed endoscopy, and we break through with a drill and then with the endoscope to open that. That was an easy case, you could say, but in the end it was a total closure, like a ligation, and nevertheless the patient has had symptoms. And we performed then afterwards intraductal application of prednisolone in single doses, 50 milligram per week, for 6-8 weeks, anti-inflammatory medication and conservative measures like just gland massage. And now we broke through the stenosis. This is the more proximal part of the duct, and this is patent. And this is the same patient 12 weeks later. You see that the duct is open after the cortisone applications. Here was the stenosis somewhere, and it is open. With a 1.1 millimeter endoscope, we can pass through, and the patient until now has no complaints anymore. So this was, let's say, type 1 to type 2 stenosis. And you also can use, I want to show that, you can use the basket here. We have quite rigid baskets. You go in with a tip and then you try to open it, yeah, like this. Or this is a type 1, more type 1 stenosis here. This one here. Yeah, you can open also with a drill. You can remove some fragments. The drill is not driven by a motor, just by your 2 fingers very, very carefully. And then you can just take away some of these tissues here, and you rinse with cortisone. You go in with the endoscope, and then that's okay. If you pass, we say if you pass with the 1.1, that's okay. We don't do anything anymore. Of course, you can use balloons like this one. These are high-pressure balloons. You can blow up them to several bar, and here is also the video. You don't really see much in the video, yeah? And I would say we very seldom use the balloons. The problem with the balloons is when they should work, they have to be inside the stenosis. So the balloon has to pass the stenosis, and then you have to open it. So you have to first find a lumen to go in with the balloon. And that's the reason, so it's blown up here. It's quite nice. This is another duct here. And it worked quite well in this case. But it is not the regular case we do. Maybe we have to develop smaller balloons, smaller instruments, or any system which will guide the balloon into the stenosis. But I think this will come in future. Okay. So another topic is if we open it endoscopically, sometimes, especially at the ostium, we have to put in stents if it's a distal stenosis, as you can see here. I think this is not a video, no. And this is the ultrasound control with a stent for a very distal stenosis. The next step will be a transoral duct surgery in combination with interventional silendoscopy plus minus a stent. This is indicated for stenosis in the papilla or distal duct stenosis. So we always have then to perform a papillotomy, distal duct slitting, and duct reinsertion together with the endoscope. This is an example for that, and I think we don't have so many patients with that, about 15 patients with mega Stenson duct. And you see here, I think that was a young boy from Bahrain who always was biting on his teeth and also on the cheeks, so the ostium was closed. So we just opened it here, and there is a little bit of trick to open that. It is easier than to use ultrasound from outside. You really can see the tip of the scissors where the duct exactly is. We went in with the endoscope, and then in the end we put in a stent. You can discuss, the opening was quite nice. You can discuss whether you use a stent or not. I think the main thing in that case, whether you should use a stent or not, is whether the gland is functioning very well. If a gland is functioning very well, I think the saliva will find its way out. Okay, let's go a little bit further on. Yeah, that was the stent then inside. So that was a very difficult case. You see here a total stenosis here. You cannot really go through. And we were from outside, we worked with ultrasound. And you see that this is the tip of the endoscope, and this is the stenosis. We tried to get through here. We did not get through in the first time. It was always very difficult. So in the end, only under ultrasound-guided control, in the end, we went in here. Yeah, it's very difficult to see, but we were inside the duct. The problem is that the endoscope is quite rigid, and so it goes always this direction and not that direction. That is a little bit the problem sometimes with the endoscope, especially if it's the masseter muscle. So this is the hilum of the gland about, and this is the dilated duct. So we went in, and one moment, try to go on with the next one. Yeah. So, and in the end, we opened the stenosis here, also under ultrasound control. I think if you haven't seen, so here the endoscope, now it's clearly inside. You see that something is moving here during rinsing. Now we are inside that. Sometimes it's difficult to see, I have to admit, but that was really a difficult case, different than the others. But in the end, we were inside and we could insert a stent here. You see that? So the stent is pulled before over the endoscope. The best is the 0.8. And now, under direct view, we push the stent forward and we go back with the endoscope, so that we can directly see that the stent is really inside. Here you see, now the stent is pulled forward and the endoscope pushed backward. And that is under endoscopic control, and afterwards, or during the procedure, if you use ultrasound, you can see the stent and the endoscope moving inside the stent. That's quite nice. It's a kind of navigation system for these methods. Okay, what were our results? We have patients with 93 patients with 111 stenosis. These patients we now had a follow-up all over the years, still now, and you see that the silendoscopy-based conservative therapy with cortisone and just going in with the endoscope was successful in nearly 22% of all cases. Then the next step, the interventional silendoscopy with ultrasound and intraductal cortisone applications was successful in another nearly 60%. And another 9% had this transoral duct surgery very successfully, and parodoectomy has to be taken out only in about 3% or in 3 patients. And gland could be preserved in nearly 70% of all cases, only 3 patients with parodoectomy. Yeah? So this is quite nice, and this is quite interesting. Of course, you see that first step is mainly in type 1 stenosis successful, the second step mainly in type 2 stenosis, and the third step, of course, in the type 3 stenosis. That is what we could find. So the more severe stenosis, the more you have to do, the more interventional you go inside. And what about stents? I just checked that because this question always appears. And you see in these patients, we had only, in this group, only 8 patients with stents, about 8.6%. 2 stents in the interventional silendoscopy group, and 6 in the very severe cases. So 6.4 of all patients, about 55% in this group. Yeah? So the more severe stenosis, the more often we tend to take stents. Maybe that's an interesting explanation when to use stents. Nevertheless, we have some important facts. Which gland is affected, the grade and length of the stenosis, you have seen that. What about the quality of the remaining duct mucosa, and also the salivary flow and function of the gland? That is also the key for success, I think. And then the other thing is, how far is the patient away from our hospital, and how often can I control him? So the more often I can control him, I would tend to not to put in a stent so often than if the patient is very far away. Want to show you, do we still have some time? Yes. Yeah? 47-year-old patient with a stenosis on the left parotid gland. Stenosis was opened and a stent put in. Some days later, recurrent swelling occurred again, and the stent was not visible in the oral cavity. That was not done in our hospital. So they performed CT scan, and you see the stent was lost somewhere, yeah? Here in the duct. Quite interesting. Here you see it in ultrasound, and what we did is that we performed an interventional endoscopy just to remove this lost stent. Yeah? That is also quite interesting. You see that sometimes you can remove hairs, fish bones, and sometimes stents from other colleagues. It was not yours, by the way, from somebody else. Yeah? You can see. That was a self-made stent, At the moment, there's a great discussion about stents. I don't know which one is the best at the moment. Stents are very expensive. Sometimes we make our own stents with the vein catheters. You can do that maybe, but you have to be careful that they don't disappear, like this one. Okay, you can do that. And in summary, I still have one other case, but I think, or we think that silentoscopy is diagnostic mean of choice in stenosis of stents and duct and important for treatment planning. Minimally invasive treatment is indicated in every stenosis of stents and duct, as I've shown you, and the gland can be preserved in more than 95%. There is a lot of literature from Naileli with success rate of 80% and Papadaki with a success rate of 100%. I'm always very, I don't know, 100% is always very, but only 18 patients. If you select the patients very well, you get 100% for sure. Atekian with 87, also 80%, and there is Kopec from Poland. It is 92%, 78 significant and partial 40%, 14%. So this is the numbers about we have. So we have now, I don't have the data here in this talk, but we made now the same patients, the 99 patients, I think, or 91 patients, 95 patients. We just controlled them now after 7 years. And we have about the same success rate after 7 years. We will soon publish that. I think this is quite a nice number. In the end, last case, you have always to be aware that you might get into a problem or trouble with this patient, for example. So we saw that image in ultrasound. It was a little bit, one moment. Can I go back? Yeah, here. Yeah. Try to go back. Yeah, we saw here a congestion of the duct. It's very irregular, really, and here was a stop of something. So we thought, is this the stenosis or what is it? We didn't know really for sure. So what we did is we thought it's a stenosis. There was a secretion like saliva, so we performed silentoscopy. And this is the video for that. And what we got was this fragment. We sent it to the pathologist, and they say, well, this is kind of some fibrotic material. Yeah. He didn't know exactly what it was, but still there was pain in that patient. Pain and swelling did not disappear, so we performed MRI and MRI, and we could see a dilation. The radiologist told this is a dilation of the duct, and I cannot really see something. We asked him, is that a tumor or not? I'm not quite sure. I cannot see really a tumor, yeah, in these images. So nevertheless, what we did then, there was an unclear space occupying lesion in the deep lobe, so we performed an open biopsy really to know what's going on here in that lady, and it turned out to be a low-grade mucoepidermoid carcinoma. So be aware, sometimes this might mimic a stenosis. It is very seldom, but you have to keep that in mind. So to summarize everything, we know that there are stenosis in the parotid gland. Maybe the stenosis are due to the illness. We know it is maybe adult chronic recurrent parotitis, because it's mainly in women. We can treat that very nicely with endoscopical means and minimally invasive means. But in the end, I think there is still a lot of space for question, where is this disease coming from? What is the reason for that? And so still a lot for us to do and to look for. Thank you very much for your comments. Thank you.
We started a few minutes late, so we'll continue on and give Professor Zenk the half an hour due here. You mentioned functional ablation of the parotid gland and not tying off the duct. What do you mean by functional ablation?
Yeah, that means that we inject Botox in the parotid gland, yeah? Yeah. And it will stop producing saliva, and it will improve symptoms. You could do that. We do sometimes, but the success is not, we are not very happy with the success of Botox.
And the second thing is, most ducts or most areas where we have an obstruction, we dilate them, and we have to continue to dilate them again and again. And you didn't talk about that. The impression I get is that you dilate this and your success rate is very high at about 98%. You don't have to go back and do them again?
Well, in most of the stenosis, we only dilated once, yeah? In the type 1 and type 2. In the type 3, you're true, we have had one patient we went in 6 times.
6 times?
6 times, after 2 months. Yeah?
But
there are some we have to do, also, normally we control them, yeah? So we perform the first endoscopy and we control them in another endoscopy after 8 weeks.
That's perfect.
8 to 12 weeks.
Yeah.
But very seldom we see a restricture, only in type 3. Yeah.
Target.
That was a lovely presentation, thank you. In your type 3 stenoses, do you worry about burring and damaging the duct wall? Do you have any problems with fistulae or with having to go on to parotidectomy because of duct damage?
Yeah, indeed it happens. It happens, especially in these, because you have to push the instruments and the endoscope forward. If it happens, yeah, we see that. So we pass with the endoscope through the duct wall, we see the normal tissue, what you see in an endoscopic facelift, the same tissue. And if that happens, we stop, we give some antibiotics, and we go in again after 6 weeks and try again. That's what we do.
Well, Johannes, thank you very much for your presentation. We have now, since 10 years, medical treatment for stricture made by the alpha blocker. Alpha blocker is used for the urology stricture, and we are doing medical treatment for very big stenosis, especially for the middle of the parotid gland. And it's working quite well without endoscopy, without stents, without any surgery, and we control just only with the ultrasound examination, ultrasound and also serography. So perhaps you can combine serography, endoscopy, and put after the alpha blocker, like for the kidneys one, and perhaps it's working very well. For me, for our experience in Paris without surgery, it's quite a good treatment.
I'm sorry that I did not mention it. We just yesterday evening we discussed that there might be muscles inside the duct or beside the duct which are responsible for that, and maybe for these kind of stenosis it works, but I'm not sure whether it will work for a really inflammatory disease. But, well, we have... Yeah, but it's a good idea. I will bring this with me home and then I will try.
Good.
So, alpha blocker.
Thank you very much. Thank you very much for that presentation. Last